Good morning, everyone. Welcome to the final grand rounds of this academic year. For this grand rounds, we're really honored to have Dr. Zannad. Dr. Zannad is a professor of medicine, head of heart failure and hypertension at University Hospital in Nancy, France. We have him by way of Brigham and Women's Hospital and Harvard, where he is visiting professor. Dr. Zannad, as many of you might know, is a world leader in clinical trials. He's made multiple contributions that have changed the way we practice medicine. Importantly, Dr. Zannad is really forward-thinking and has organized a annual meeting that I think is the best meeting I've ever gone to, where he brings together people from academics, from industry, and from the regulatory agencies, and they come together to kind of discuss how we can improve the healthcare of patients, and that's how I got to know him. He is incredibly committed to junior faculty and fellows, which is an incredible thing about him as well. So it's a big honor to have him here. First time in New Haven at Yale. Unfortunately, it was raining, but I assure you it is a beautiful city during the summertime. So now you're a member of the Yale cardiology family. Hope you wear this, nice. Especially up in Boston. And with that, thank you.
Thank you so much. Thank you, Tarek. Thank you, Eric. Really my pleasure being with you here today. And thank you for your kind words and for highlighting the CVCT meeting, because he didn't name it. The meeting is CVCT, and it's early December. It's actually in the French Embassy in Washington. And it's anything you need to know about cardiovascular clinical trials during the year. And I really wish you all to come and mingle with the great faculty there. It's small, it's kind of a boutique meeting, and you'll meet every PI in the major fields, and regulators and industry and payers and patients, and lots of young investigators. So the topic of my talk today is mineralocorticoid receptor antagonists, because this is the main area where I spent most of my 20-30 last years. I met Eric, it was 25 years old when we were both working on the very first FlowLand program in the first trial in acute heart failure. But since then, in this kind of space, we haven't really done major progress, but certainly in chronic heart failure and with reduced ejection fraction, we have done quite a great job. And one of the contributions is MRAs. These are my disclosures. And I would like to just highlight where we came from, because yesterday over dinner, the question arises, how did you get to the idea of trying MRA in heart failure? And then just examining quickly the evidence so far, and focusing on implementation, because we are always disappointed of contributing great trials, great science, but not necessarily reaching the patient. And I will end up by some mechanistic insight and some reverse translational and some basic science in order to understand how all this works. So this is just in a nutshell the continuum of changing practice, and indeed anything we are doing is hopefully to change practice and to improve outcome in our patients. But occasionally we need to circle back to the bench and understand how this works and whether we can learn more from this experience in order to come up with even better targeted therapies. So it started in 1993, where at that point, ACE inhibitors were on the rise, and everything was focused on this class of therapies, and everybody has forgotten about aldosterone. And the knowledge of this, and the oldest among you, maybe I am the oldest in this room, we have learned that aldosterone is simply a hormone which is only regulating sodium and potassium. And if you block converting enzyme, you've done your job. Aldosterone should be blocked. And at that time, in the textbook, combining spironolactone with ACE inhibitors were kind of totally contraindicated. So it was against this belief that we had drafted this concept paper published in an obscure supplement of the American Journal of Cardiology, come in with the data which were all there, but nobody had really taken the pain on putting them together. The spironolactone may exert direct cardiac and vascular effect, not only renal, that aldosterone escapes actually continuous converting enzyme inhibitors and ARBs, and even if you put them all, you still have, after a couple of weeks, aldosterone rises again. So you need to make your job into block aldosterone per se. And we had this consensus trial where half of the patients were taking actually spironolactone when enalapril was added to the regimen. So we had produced this concept, which was behind the RALS trial, that combining ACE inhibitors and spiro may achieve a more complete inhibition of the whole renin-angiotensin aldosterone system and may produce further clinical benefits. So why aldosterone is bad? This is summarized actually in this slide. Since then, and actually at that time already, we had evidence that aldosterone is active in the cardiovascular and the renal area much more and much beyond sodium and potassium regulation. It acts on endothelium in the large and smaller vessels. It acts on inflammation and more so in fibrosis. And I'll get to that later when we'll have some mechanistic insight in this talk. And the very important point here, which made us really move toward this trial, RALS, was this trial that you all may remember, the founding first evidence-based trial of enalapril versus placebo in severe heart failure patient. And it was in the paper, New England Journal of Medicine, and I'm sure that if I would have asked you, you wouldn't really have guessed that actually half of the patients were taking spironolactone and at a very high dose, 75 milligram, because at that time, this was used just as a diuretic in severe heart failure and diuretic-resistant patients. So the combination was there. Half of the patients had this combination. True, there were more worsening renal function, more hyperkalemia in this group of patients where the combination was there, but the benefit was much larger than the harm. And if any, the concept of combining these medications was already pre-tested and the proof of concept were there in consensus. And so we had it all, and we have this aldosterone and MRA as Sleeping Beauty. And I had to meet Bert Pitt, who was the charming prince, who got to waken up this Sleeping Beauty. And here we go. So we came from this picture on the left-hand side where aldactone was a diuretic used at high dose just for relief of intractable edema. This was the indication at the time. And it was great because it was potassium sparing, it was complementing the action of furosemide. But the real important trick, and this is the very important point that we've made with Bert at that time, is that we thought we may not need these large doses. Let's check out very low doses. And we started with a dose 12.5 milligram. On average at that time, we were using 75 to 150 milligram. And at that time, we didn't talk about BNP. It was called atrial natriuretic factor. So it was the BNP, and we measured it. And you can see that there was a very profound and significant effect at this very small dose. And we said, this is where we'd like to go, because we keep away from the risk of hyperkalemia. And in order to make a long story short, we had these 3 trials. And this is the beauty of clinical trials. If you get this level of evidence of external validity, it goes across 3 categories of heart failure: RALS, very severe heart failure patient; emphasis, heart failure within the context of acute myocardial infarction; emphasis, mild, moderate symptoms with all of them were reduced ejection fraction. And you can see the level of risk changing from 1-year mortality from 27% in RALS to 13% in emphasis and 7% in emphasis. So across a large spectrum of severity, and across 2 agents, actually, eplerenone was a more selective MRA than spiro. This is typically what we call external validity. This means that the evidence is extremely strong. And if any, it is stronger than the evidence in heart failure with ACE inhibitors, because we don't have that kind of multiple product and multiple severity cases. Now, a couple of sub-analyses we have done over the last few years. What does that mean to the patient? We had this estimated long-term survival with eplerenone. You are used to see the Kaplan-Meier with the vertical readings. We have tried the horizontal reading. How long typically a patient can gain as a life expectancy from exposure to eplerenone in this trial? It's an average of 3 years of life expectancy for an average age of 6 years. A patient of 6 years exposed to eplerenone would live 3 years longer. This is absolutely remarkable. Then, of course, we wanted to see the consistency, which we call internal validity, across a large number of subgroups. And we have done many subgroup analyses: the elderly on the upper left, diabetes, patient with low blood pressure, and patient with ejection eGFR below 60. And you can see very, very strong consistency across all these subgroups. And if any, these high-risk population, elderly diabetes with poor renal function, they had higher risk, absolute risk, and therefore they have higher absolute risk reduction. And keep that in mind, because these are the patients who are being deprived at this time just because of the concern of side effects. So we shouldn't really deprive these patients from life-saving therapy just being concerned about safety, because these are the patients who need most this therapy, and I'll get back to that later. And this is according to the risk model with the many risk factors, modeling subgroups of patients with low and high risk, and you can see that the medications worked out across the large spectrum of risk, and the higher the risk, the higher the absolute risk reduction. We have looked at whether there are subgroups who may benefit more, and there was out in literature that the adipocyte actually can synthesize aldosterone, and they have MR receptors, and there is a large evidence in the hypertension field, at least, that in obese patients they have more frequently primary hyperaldosteronism. And therefore, we thought that obese patients, at least with abdominal obesity, may benefit more. And this is actually what we found in the emphasis trial, in a subgroup analysis. The obese benefit most. That doesn't mean that the lean patients do not benefit. They do. But the more obese, the more benefit. And we are digging into this further in order to find out whether there is really a precision medicine track that we can pursue from this subgroup analysis. We have also, like Tariq has told us on putting all the data together, shaking it up, and try to have this, what we call the data-driven approach, and whether we can find profiles of patients who would benefit more or less. And this complex network analysis and multiple phenotyping did find out that actually, yes, if you are old, lean, with anemia and poor renal function, you have more side effects, less benefit. So the benefit-to-risk ratio is not so favorable. So this means that we really need to be very careful in dosing and in monitoring in some subgroups of patients, and I'll get to that later as well. In myocardial infarction, we had the FSU study. This is myocardial infarction with poor ejection fraction below 40 and signs and symptoms of heart failure. And the trial was positive with a 15% reduction of all-cause mortality. And then patients in this trial were randomized between 3 and 21 days after the onset of myocardial infarction. On median was 7 days. So we have done this analysis, whether the earlier the better, and this is what we found out, because at that time we were concerned that people and doctors were concerned to start this medication early in the emergency or in the CCU, and they waited until the patient are discharged. And actually, this is not the best practice. The best practice is to start the earliest possible. And you see the benefit was really front-loaded in patients who are randomized within the first days after myocardial infarction. And because there was a reluctance in using this medication, true, in a very busy period when patients were admitted for a myocardial infarction, acute coronary syndrome, they had to have antithrombotics, they had to have revascularization, initiation beta blockers, ACE inhibitors. So people and doctors tend to forget about this. So we said, well, how if we get these drugs on board very first, before actually revascularization. And we have done 2 trials, small, just safety actually trials, because these were not large enough. And Albatros was with Spiro, initiating with potassium canreonate, which is the active metabolite, because Spiro is a prodrug and it needs at least 48 hours before it's activated. So the patient got in the hospital before actually we can even measure creatinine and potassium. He got injected with potassium canreonate and immediately taken over with Spiro. And this was, again, a small trial, 1,600 patients within the first 72 hours, STEMI and non-STEMI. And the results was, of course, a hodgepodge of a large composite endpoints, because we didn't have power enough in order to only go for morbidity and mortality. But at least in the STEMI population, the trial was positive. And again, this patient did not have necessarily heart failure. They had normal ejection fraction. And in the global population, the trial was neutral. But in patients with STEMI, the trial was positive on this primary endpoint, which is actually rise in BNP, decrease in ejection fraction, sudden death, and many outcomes in the acute phase. And we have repeated this with another trial called Reminder, published in the European Heart Journal a couple of years ago. But this time was eplerenone, 25 to 50 milligram, and randomized within the first 24 hours, and only in STEMI. And again, we had this very important effect on this very large composite endpoint, just showing that initiating the drug very early is safe. And this was actually the primary outcome, but it may be useful as well. And this actually should be the foundation of a future prevention trial, because one of the main issues in heart failure is that we have a high incidence, and we are doing nothing in really stopping patient becoming heart failure patients. So in the next frontier with MRA is a prevention trial, heart failure prevention trial, whether it is like, the acute myocardial infarction with ACE inhibitors, like Valiant, like other trials. And if Valiant, for example, we had really selected eplerenone instead of valsartan, maybe the trial would have been positive. In these acute myocardial infarction trials, safety was reasonably good, and you can see that there was more hyperkalemia, as in all these trials, and we'll get to the potassium issue later on. But just to highlight that consistently with all other trials as well, we had much fewer hypokalemia. So no pain, no gain. You have really both sides of the coin, and potassium is very important player. So of course we don't want much to induce hyperkalemia, but it's good to prevent hypokalemia, especially in the setting of acute myocardial infarction. And actually sudden death was decreased significantly within the 31st day after acute myocardial infarction. So potassium is a key player, and it's key mechanism of action, although it may be some head downside to it, and I'll come to that later. Another trial which was disappointing is Athena, and I wish that Eric has taken this trial and have made it a success like Pioneer, because in Athena, this was a large dose of spironolactone, the oral compound, in patients with acute heart failure, and the trial was neutral. And we have drafted a paper showing that there have been many caveats in this trial, and one of them is that they stop at follow-up at 96 hours when you may have expected that Spiro may start to be active, because it has only 48 hours before you can see anything. So if any, in acute situation, we should use potassium canreonate, which is the active metabolite, or wait longer until you can see something. So I discussed with Dr. Braunwald with this specific situation, and we all agreed that this has been, unfortunately, a missed opportunity. So it doesn't mean that MRA are not active in the setting of acute heart failure. It does mean that we need to do a proper trial. TopCat is another big disappointment, and the main reason for this is that we came really, and we are still in the area where we have no cure for HFpEF. Although you will see in the future we have posted a couple of papers which are going to be published soon, that the reanalysis of iPreserve and TRAM, actually adjusting for baseline differences, found out actually that these trials were positive. So we may have some medication in this setting of HFpEF, but if we have it for face value, TopCat was negative or at least neutral. And you may remember that the main reason was this Russia and Georgia contribution of very, very, very healthy heart failure patient, and to the point that we are not sure they had heart failure. And you can see there have been 5-fold difference in event rate between Russia and Georgia and the Americas. So we dug into the data, and we found actually that patients who were randomized only on the basis of history of heart failure as an inclusion criteria, this is where the trial was neutral. And we have published this paper finding out actually about how patients were randomized, and a strata of the patient were randomized on the basis of BNP. This is strata, pre-specified and pre-randomization. And you can see that in patients who've been enrolled on the basis of high BNP, the trial was positive. So if really you select the real patient with heart failure, you have a better chance to show that Spiro is effective. And many people are now using spironolactone in the treatment of HFpEF because we have nothing else and because we have some evidence that it may be effective. So I believe that we have really now 4 ACEs, although we wish to see a confirmation of the TopCat trial. And there are 2 trials, both of them are actually called SPIRIT. One is SPIRIT with 2 R's, which is a randomized rigid trial in Sweden and in this country. And the other is SPIRIT trial in Germany, which are very similar to TopCat, and hopefully we'll have confirmation in the space of HFpEF. So getting back to HFrEF, where there is the strongest evidence, you know this slide and how much we have been de-escalating the risk of patient. Wonderful work over the last 25 years. I don't know of many diseases where the mortality has been decreased threefold in the matter of 25 years. You can see whether it is in the severe heart failure or on mild moderate. And the right-hand side, you can see sudden death, which has also decreased across all the 20, 30 years with the accumulation of benefit of the various medication. So as now the residual sudden cardiac death in the setting of chronic heart failure is only 4 to 5%, which actually is very important. This means that you may need to reassess the guidelines in this patient population, because we are not going to be surviving implanting 100 ICDs just to save 4 or 5 lives. So there is a persistence here in discussing whether the guidelines should be re-challenged, and some of this has been already challenged with the Danish trial you are familiar with, which has shown that actually, especially in the elderly, ICDs may not be the solution in this group of patients because the residual sudden cardiac death is really low. So we came to this consensus of very large and strong evidence and very strong recommendation. And the issue is whether we are able to use this medication and take this benefit to our patient. And we have here 2 celebrities. We have our own celebrity in France, but we have to go back a number of centuries back in order to find out actually before Bill Gates, we had already mentioned that we really need to apply and implement. And I know that this place is very keen onto implementation science. And let me take you through this issue of implementation, because we have done a wonderful job, but patients are not taking advantage of the medication, and mainly because of the excessive concern of hyperkalemia. The exaggerated concern actually last year or 2 years ago, because of the newcomer, the potassium binders, hyping all this stuff of hyperkalemia. When I walked in the hall of the American Heart Association, we had this huge poster, public enemy number 1, hyperkalemia. So making you really feel, wow, hyperkalemia. So, and now hyperkalemia is here to stay. And this is the dilemma of this medication. They are great to decreasing proteinuria, blood pressure, CV death, and heart failure hospitalization, but they all This means ACE inhibitors, ARBs, MRAs, and sacubitril valsartan. So how to get around this? Of course, education. There may be some solution with home monitoring, disease management program, and potentially potassium blinders. Now, when Spiro came to this country, you didn't have much experience, and in Canada as well, of using Spiro, while in Europe, we have been using it for 20, 30 years. And you may remember the Gerling paper, New England Journal of Medicine, showing that just after the release of results of RAS, there have been an epidemic of hyperkalemia hospitalization in Canada. And this was New England Journal of Medicine. So it really made people really scared about hyperkalemia. So what happened in Europe? Exactly the same study, population-based. This is in Scotland. Not a blip after the race. So no, just because of education, people were prepared. We knew that we need to monitor potassium. We knew that we had to play with the dose. So, and when you go for registry data, you still have a very important lag of the use of MRAs, and more so use of the appropriate dose. And the main reasons are hyperkalemia and renal dysfunction. And this is true across all the spectrum of indication, whether it is diabetes, heart failure, or CKD. And you can see it is bad news. These patients are not on this medication or having discontinued. Some people may feel comfortable on using small doses. And you can see the submaximal dose outcome is similar to discontinuation. So you really need to do the job and use the appropriate dose, because it may be reassuring for you, but not necessarily for the patient to use small doses because they are not effective. So all this medication work on the renin, angiotensin, aldosterone system produce hyperkalemia, and expectedly so in RAS. We had a rise in potassium, but you see, we using the small dose, in average it shows from 4.3 to 4.5, but true, there have been hyperkalemia more frequently. And I mentioned yesterday over dinner that actually over all the trials, MRA trials, we had one death related to hyperkalemia in Ephesus, and this was related to placebo, in the placebo group. This is because this was trial conditioned. We were monitoring potassium very closely, and we had an algorithm of adapting the dose. Now, adapting the dose is critical. And in emphasis, actually, we had a stratified dose initiation. This has been published very recently. We didn't really get that out, and we believe it is a very important message, because in the guidelines, it is one single dose which is advocated across all the spectrum, whether it is American or European guidelines. We believe the guidelines should be changed. You can see here that patient with eGFR below 50, we initiated only the smaller 12.5 milligram. And at this 12.5 milligram, in this subgroup of patient, it was as effective at 25 to 50 in patients with normal eGFR. So we need to play with the dose, initiation, and also across the continuum of follow-up, and decrease the dose rather than stop medication. But the main issue is how much this hyperkalemia is tolerated. Well, it is better tolerated in patients with MRA than in patients on placebo. See the upper hand, the slide where we have the U shape, and again showing that low potassium is bad for you, so it's good to treat low potassium. And if any, one of the contribution of these medications is actually to treat low potassium. But high potassium is bad for you. But then you have the blue and the yellow curve. And if you happen to have 5.7 milliequivalent, you are better off being on a Spiro than being on placebo. Again, it's all a matter of benefit to risk ratio, because you do benefit more than the risk which is conveyed by hyperkalemia. And we and others, Patrick Ossignola and many actually in our group and others, have published repeatedly that you really need to persist and keep up with the dose, even though you may produce some sort of hyperkalemia. And hyperkalemia is manageable, is reversible, and this is the work we have done with the group in Spain, showing that if you revert hyperkalemia, you get back to track and a normal risk. It is only persistent, durable, chronic hyperkalemia, which is really an issue. So hyperkalemia needs to be mitigated by frequent monitoring and persistence. And you can see this is not happening in the real world. Monitoring is really low. People, on average, have one potassium check once a year, while during the trial and in the guidelines, we had to monitor potassium 7 days after the initiation, 1 month after the initiation, and every 4 months. So on average, this is 4 to 5 times a year, and adapt the dose. And you can see here, most of the doctors would stop medication altogether, not necessarily play with the dose. And more worrisome is that once they're done with stopping the medication, nobody will reinitiate it again. So patient will be definitely deprived from these life-saving medication. And anything I'm saying here is true for converting enzyme inhibitors and ARBs as well, and sacubitril valsartan. This is risk aversion. Doctors prescribe more from risk aversion than from the benefit. Now, one of the solutions is disease management program. This is one disease management program. Many others, and I know you have yours here. This is ICALOR, insuffisance cardiaque en Lorraine. Lorraine is the region where I live, and showing that if you really have home nurses with an integrated, coordinated system, you can decrease the readmission rate 40%, mortality 35%, just making the doctors make a better job and persist with the medication, have more frequent monitoring. And I will skip this. And the other solution is home monitoring. And we have developed with Patrick Rossignol, a nephrologist in my group, a new startup called Cardiorenal that we are just in the setting of the technical hurdles at this point. So we are starting a proof of concept trial by the end of this year, based on the monitoring of daily potassium, creatinine, and hemoglobin in a droplet of blood, like diabetes people just measure their glucose. Very simple, and of course we have an expert system which would instruct the doctor based on potassium, creatinine, and hemoglobin. Hemoglobin is being a surrogate of congestion, how they can play out their medication with the hope that this may enable optimal prescription of life-saving medication. So this is yet to be demonstrated. And finally, the potassium binder story. They may help, whether certainly we, in the Pearl, HF, and other trials, we have shown that potassium binder may help people keep up with higher doses, but whether this is translated in a clinical benefit, this is going to be investigated in this trial, the Diamond trial, which is going to be a randomized patient to receive patiromer or placebo, patient at risk or having had developed hyperkalemia, with the hope that to keep up with the higher doses and hopefully having a better outcome. So I will now spend just a few minutes on how MRA work. Well, some of my good friends, Milton Packer and others, believe that we don't matter. It's not important to know how it works. The most important, it does work. But we do believe that it's important to know because we can have ideas in order to develop smarter and better tolerated drugs. And our, main focus was fibrosis, and you are familiar with how much fibrosis, not only in the heart, I'll get to that later as well, in the kidney and other organs, fibrosis, and the antifibrotic effect of MRA, how much it is contributing. We have two big European programs that I have the privilege of coordinating, called FibroTarget and HOMAGE. I'll take you through very quickly. This is a busy slide showing that we can measure fibrotic biomarkers in the blood, and they have been related to how much fibrosis is in the heart. And if you measure them, these are synthesis biomarkers, P1CP, P1NP, P3NP, pro-collagen peptides, or degradation, the collagen TIMP and metalloproteinases. And across many trials you have seen earlier, the RAS, Reminder, Ephesus, consistently MRA decrease the fibrotic biomarkers. And you can see it here in the Ephesus trial. The 1 month after the heart failure, the onset of myocardial infarction, you have a very steep rise in fibrotic markers, which is totally blunted by the use of MRAs. And this is the chronic situation in RALS, similar buildup of fibrosis in patients with heart failure, but not in those patients who are exposed to MRA, and similar situation in Ephesus. Now, what is very important is that if you have high level of these biomarkers, the prognosis is really bad. So they are prognostic markers. And most importantly here is subgroup analysis based on baseline fibrotic profile. You can see that in the patient who had the largest amount of fibrosis, this is where patient benefited most. The very patient, same kind of severity, if they happen to have low fibrotic profile, they didn't benefit from medication at all. So we are really investigating deep into this, whether we can do precision medicine and select patients who are most likely to respond just based on their fibrotic profile at baseline. One other observation is in emphasis is new onset atrial fibrillation, which was decreased by eplerenone. So there is kind of prevention of atrial fibrillation in patients in sinus rhythm in heart failure. And this corresponds actually most likely to the antifibrotic effect. You know how much now electrophysiologists tend to believe that atrial fibrillation is a fibrotic disease in the atria. And by the way, this is the case in histology, but also using the biomarkers, which show actually that there is a distinct biomarker fibrotic profile in patients with high recurrence of atrial fibrillation and high incidence of atrial fibrillation. So this may be another benefit of MRAs. And the FibroTargets program we have developed was trying to find out what are the key molecules which have the relationship between aldosterone and fibrosis in the heart and in the kidney. And we have contributed a white paper in circulation focusing on the cardiorenal syndrome, which should be revisited. In my opinion, cardiorenal is a fibrotic disease, a systemic disease. And we did find out with a number of experimental papers that in rats, if you use invalidation of the various key points here, cardiotrophins, ST2, galectin, NGAL, or a microRNA, which is involved in fibrosis, if you use knockout against any one of these molecules or pharmacologic inhibitions, you will totally negate the fibrotic effect of aldosterone. So we do have actually different mechanistic pathways explaining the fibrotic effect of aldosterone, and we may not need in the future to use MRA if we really only target the antifibrotic effect. And we have now at least 3 compounds at the early stage of clinical development which are mitigating these key mechanisms downstream aldosterone. Now, the proof of concept needs to be taken further in what we call a precision medicine approach, and this is the HOMAGE program that we have developed recently, and this paper had just been published a month ago, with a complex network of patients at risk of developing heart failure. And we have used a multi-omic approach. I'm showing here only the proteomic approach, and not only for prognostication, but more so for mechanistic clustering. And you can see that in patients at risk of developing heart failure, there are 3 main mechanisms. Most of the biomarkers cluster around 3 different mechanisms. One of them is inflammation, you may expect, but the other one is very importantly, so extracellular matrix fibrosis, and the third one is blood pressure. So this one on fibrosis is an important target we'd like really to use in the future. And we would like to develop a proof of concept trial where patients are profiled on their fibrotic profile. And using this, we have gone into a trial called HOMAGE, and the results of the trial are going to be given at ESC. We have filed for late-breaking trial. And the objective is the examination whether the antifibrotic effect of spironolactone can be predicted and whether responders can be described at baseline with using a multi-omic approach. This trial has been terminated now for 500 patients, and compared to other HFpEF or at-risk population, actually we had a sick population. These were stage B heart failure. None of them was symptomatic, but they have already some very prevalent echocardiography differences and high BNP, but none of them were symptomatic. So I'm sorry, I need to invite you to the ESC, and it is in Paris, by the way, my city, so I'd love to see you all there, and I will then share with you the result of this trial. So I will stop here, and with just a few future consideration. The future is bright. We have many new MRAs coming abroad, and some of them are non-steroidal, and two big trials in this space of diabetes kidney disease, again, targeting the kidney and the heart, the cardiorenal concept. And these two trials are Figaro and Fidelio with finerenone. Two twin trials, by the way. Both of them are enrolling patients with diabetes kidney disease, but one is a cardiovascular morbidity mortality endpoint, and the other is progression of kidney disease. And this is becoming very fashionable because the SGLT2 inhibitors, we have this kind of similar approach where we have renal on the one hand and cardiovascular on the other hand. And this is just to show that there are multiplicity of targets, and the drug can be used really a very large number of diseases. And one thing I really am proud of is making nephrologists who were really obsessive about the use of medication, and actually they nearly hated me. Well, they hated me actually when we have started, because they said, oh, you are going to be just killing the kidneys of our patients. And then they have warmed up to love this medication, and they are doing nephrology trials, and one of them is the Alchemist. Others are Achieve, the group of Salim Youssef, having a very large trial in end-stage renal disease for cardiovascular prevention. And so far, so good. In this trial, the risk of hyperkalemia is not excessive, and DSMB has not risen any issue in a large number of patients with end-stage renal disease. So I'll just have two final slides showing that anything we have found initially is really a product of serendipity, and just quoting our colleague from France, Pasteur, that incidentally we really stepped into this. We didn't believe that we will get all the journey around, and you have seen how all of this has started. But of course we had luck, and we haven't been lucky all the time. Just to finish up on this note of humility, the heart failure trial experience is a very humbling experience. We have failed well, actually we have failed more frequently than we succeeded. And the highlighted red trials are trials where I was at the steering committee or PI of, and you see that I have many more failures than successes. Many more trials which failed, and actually even trials where we have killed patients. The latest where I was involved was SERVE-HF, CPAP in patients with sleep apnea. We increased mortality, right? So we need really to be very humble, but this should not stop us from being creative and still very hopeful. Thank you so much for your attention.